Good afternoon and welcome to the 2025 Fall Showcase and Awards Program hosted by the IU Indianapolis Center for Translating Research into Practice. For those that are here in our audience, there's been some great buzz going on already. There's a lot of interest in the research being shared here, and we're going to have a chance to get back to that later, but we want to break the action for a few moments and do our formal program so you can hear about some of the awardees and some of the work that's going on with them, and hear from some of our esteemed colleagues. So my name is Steve Vieweg, and I'm the director of the Center for Translating Research into Practice, and I'm pleased today to serve as the host for this esteemed event. And we're glad that you're here to help celebrate research that is interdisciplinary, involves students, community members, and faculty, and generates or uses knowledge to solve complex problems. So we hope that you'll learn more about the amazing translational community engaged scholarship here on our campus. And one way to do that is to follow us on social media, and we'll take any way that you prefer. We try to keep up on it. You can also check out our YouTube channel. This event will be stored there as well, but there's lots of things that you can check out if you want to learn more. So quick reminder, if you haven't already, get out your cell phone and set it to silence for a little bit so we can give our attention to our awardees as we honor and recognize their work. We are very grateful to our founders, Chancellor Emeritus Charles R. Bantz and Dr. Sandra Petronio. Their passion and commitment to translational community engaged scholarship is the foundation of our work at the center. Sadly, Dr. Petronio passed away this past year, and we continue to realize her dream of creating spaces to recognize, honor, and promote research that's translational, interdisciplinary, community engaged, and solves problems. Well, we'll hear more about the center's legacy from Chancellor Emeritus Bantz, but first, to bring a warm welcome to our campus, I'd like to invite our Chancellor, Latha Ramchan, to the podium. Latha continues to advance our campus to new heights and connections for our students as they enter the workforce. We're delighted she's here with us today. Give her a warm welcome.
Can you stop that?
Okay, you can.
Thank you. Thank you so much, Stephen. And thank you all for being here. As Charles and I were walking here, I was just thinking about, I think many of you here have something that I don't have, which is you knew Sandra Petronio. And I think we're all here today celebrating the passion and the commitment that she had to ensuring that our research really creates impact, right? And I say this a lot. I go into a lab. I'm not a scientist in the lab sense of the term, but so unless you can help me understand why those yellow cells that you're so excited about, why do they matter to me? Unless we make that connection, and Sherry's nodding her head, I don't know that people understand the impact that we're making. But that's really tough because we're so trained to focus on a small topic and to delve into it deeply. We just assume that everyone in the world has the same prior knowledge that we do, right? So in our eagerness to get as much as we can, we sometimes tend to not forget, but maybe not think about translation, the translational aspect of science. And if anything, in today's world, that is so important. When science is being questioned, when science is being degraded, when science is being described in ways that make us all very uncomfortable, we don't want to say things in a way that seem uncivil, but at the same time, it is incumbent on us to point out the truth as science would have it, not as my opinion would have it, not as my adjective would describe it, but really, what does that chi-square Cronbach's alpha statistic tell you about impact? And I think every one of you here today, the fact that you're here and you see that connection being important, that says a lot about who we are as a campus. Because at the end of the day, that's what we need to do more of. We can say, they don't understand us, but we don't have any leverage today unless we make the effort to explain what we do in a language that that person who maybe has not gone into a university, much less a lab, can totally understand and see its impact being felt. And every one of our award winners, I know we were talking about this, Charles and I, that is, to you all, it's about the human condition. It's not just an experiment, it's not just a paper, it's that dedication you bring. When you see, when I hear Joseph talk about, I started considering investigation along this track, and I learned that this is now going to open me to another study, and the excitement that you bring on those discoveries is what's going to make this university be here and grow stronger for the next century. And I am so grateful to Charles, to Sandra for allowing us the luxury to do this, because it doesn't happen at every place. It doesn't happen at all at every place. We take it for granted that we know how to communicate that, but that's really hard. So the fact that we are incentivizing you through the support that Charles and Sandra have facilitated to think intentionally about your impact as it affects our community, as it affects human beings in ways that we relate to each other as human beings, not necessarily as scientists or not necessarily as investigators. That is, I can't tell you how important it is and how honored I feel to be at a place. Whoops, what happened? It moved. No, I don't want that to be seen. No, seriously, how important that is. So thank you again to every one of you for the work you do. Thank you, Charles. I wish I had known Sandra, but I know she is with us in many ways. And a huge thanks to this young man here. Yes, young man. Without him, this would not be happening. To Stephen and his team for, again, the dedication they bring to bear on this very important task. So thank you all for being here, and congratulations to all our award winners. Thank you.
Steve asked me to say a word or two about how this got started. I know a bunch of you have heard the story, so I'm not going to make this a long one. One day we were driving home early in the time we were here. I lived up on Sunset Lane, and we were driving home probably up Meridian, God forbid. No, maybe we ran along the river. And Sandra says, I was driving, Sandra says, this is the most translational campus we've ever been on. And I knew what she was talking about because Sandra had published a paper back in the 90s about expanding translational work in our discipline. And she'd been a president of an organization. She published that. And we'd talked about it numerous times. And I sat there and I'm driving, paying attention, of course. And I'm thinking, okay, we met at the University of Minnesota on the faculty, and Minnesota's a land grant. And Minnesota occasionally really owned the urban part of their mission. And I won't say they always did, frankly. And I had a friend who tried to move them that way from the top of the institution. I had been at Ohio State as a graduate student. You had a sense that it was so big. It was kind of in Columbus, but took over a whole neighborhood. But it didn't feel very engaged, except sort of in the clinical sense, because these both had hospitals and medical schools. And then we went to Arizona State, and Arizona State's a very strange place because it was never a university till the people of the state voted it to become a university over the objections of the University of Arizona. And I kid you not, that's how it happened. And it's in the bigger city by far. But there was some mission commitment there because we had a president that said, he had 4 pillars. There were 4 pillars the day he showed up. There were 4 pillars the day he retired. They were the same 4 pillars, and he nailed them. And one of them was to be engaged. So they've been pretty focused on that under his leadership. And I'd been at Wayne State, Sandra and I had been, which is as urban as it gets and is pretty engaged in the community. Again, understating it. But it was here. It really was here. Part of it's the tradition of the professional schools. Thank you. Medicine was here early on. Heron claims to be the oldest of the schools because it preceded the university being created. Dentistry's old. We look around and say, we've been here a long time. We have a lot of professional schools. But what was different was the proportion of people committed to engaging with their research into the community. And of course, some of you in this room illustrated this from the very beginning to Sandra and I. You can't be around Riley for very long and not say, dang, these people are really serious about their community. And I've been in Sandra and I went to Eldoret. So it was pretty clear that I got the memo very clearly that this was about learning to be a great physician when you don't have all the resources that you do in Indianapolis. And that's how that partnership started, that and the Soviets invade Afghanistan. And I can go on and work through the other schools, and some of you in the room can do the exact same presentation. That's how we got to this. And as a result, Sandra said, we need to have something to celebrate that work and the people who do it, because it's hard work. And some of it's really tricky work. You don't have to be chased out of Afghanistan by the Soviets to know it's difficult. There are some issues in our neighborhood that we had to confront and help deal with. On the east side, the poverty and health issues, serious problems. We had issues here that we needed to deal with. It's tricky to do that. So I was thrilled when Sandra said, I'll talk to people about whether they're interested in trying to create a center that celebrates faculty work, it does of this type. And she set off and she met Steve. And that is one of the accidental secrets of how this all got going is Steve and Sandra are the two who went around. I showed up when somebody basically roll in the chancellor. But that works. They did all the hard work. And it was the right moment, I think. The CTSI hadn't been created. We had to, when that started, we had some conversations saying, we are not in your business. We're in celebrating. We will not compete for grants. We will not do anything but celebrate the work and bring people together. And that's sort of been the path we've been on. And the reason we're still on that path is Steve, because we had to have continuity, and Sandra was engaged deeply, but life moved in different ways, and she never stopped writing things. I want you to know. I'm still working on that. So she moved. I ended up not being chancellor after 12 years, I did the happy dance and said I didn't get fired. I'm on my way out. But one thing we did do is we created the fellowship. And I have to tell you, there are not many decisions you look back and say, that was one good idea. And if you have not looked at the webpage and looked at the various fellows and the people who've won the Bantz-Petronio Trip Award, do that. Some night you're feeling crappy about work and the things, look at what's gotten done. I'm serious, I do this. I go back, sir, that's how you remind yourself, this is an amazingly good place and good work gets done, but it gets done by you. Didn't get done by me. Sandra did some of that kind of work, but she would say, if she were here, it's about celebrating your work. And that's why you're here today. And I'm going to stop with that. Thanks.
Well, thank you, Charles, for helping us remember the beginnings. And thank you, Latha and administration, for supporting this work. And you mentioned this is, I've done a lot of hard work, but really the hard work is by all of you. And that's what we're here to celebrate today. It's an honor and a joy for me to get to do this, just to hear about what you do and to help promote it. So let's get started with that. The first award that we're going to talk about today is the Bantz Community Fellow Award, which was established in 2016 in recognition of Charles R. Bantz, who firmly believed in the power of community-engaged research and university community partnerships that make lasting impacts in our lives in our state, nation, and beyond. The award is granted for 1 year to support a collaborative research team that's made up of faculty, staff, students, and community partners and other members to address a pressing community issue in Central Indiana. So the physical award, where'd it go? The physical award here is presented today. It is designed by a Heron School of Art and Design graduate and now associate faculty member, Christina Hollering. Is she here yet? Oh, she's online. Okay. Well, she calls this award Ripple Effect. Ripple Effect was inspired by the William Shakespeare quote, "How far that little candle throws his beams, so shines a good deed in a weary world." This quote, commonly associated with the 1971 movie Willy Wonka and the Chocolate Factory, reminds us that the smallest of deeds can make a big impact, an impact that reverberates and grows exponentially, creating a ripple effect and touching those around us. The ripples are illustrated using concentric steel circles that form the top portion of the award. An orange acrylic flame is nestled within these ripples. The flame represents the light we all carry within us, and like the beams of the candle in the Shakespeare quote, it has the potential to spread far in a world of darkness. Once the light within the award is turned on in a room of darkness, multicolored ripples are cast onto the award's surroundings, further illustrating the ripple effect. So we thank Christina, who's watching this today, for creating this award. So please give her a warm welcome and a thanks. And now it's my pleasure to welcome to the podium the 2024 Bantz Community Fellow, Dr. Gregory Dreschel, who will provide a brief update on his project, but also then introduce this year's fellows. So welcome, Greg.
Thank you, Steve. Thank you very much. It's a pleasure to be here and to give you a bit of an update on what we've been doing for the past year in terms of looking at the way that we've tried to develop community partnerships as a conduit from a new course in an urban field setting to an undergraduate research experience to provide what we hope, and I think have successfully done in a few examples, useful, actionable information to a number of our community partners in terms of what we're doing. And so the idea with this is based on trying to develop relationships with community partners. And that's really looking at our role as a resource to the community instead of the community as a resource for doing science. We're really trying to develop what we kind of think about as science as a care practice, an ethical construct in which we're training students to listen to the community, listen to the people that are in the environment. I always tell my students, these people have lived here their whole lives. They know a lot about it. Maybe they didn't take a class in earth materials, but they know a lot about it. We need to listen to them, think about what their concerns are, and also get their perspective. It's critically important. So the class is structured to train students on science as a care practice with teamwork approaches towards this problem solving and how to communicate these kinds of things with the community. And so we tap into these a palpable and real student passion about their neighborhood, their communities, and really it's just this desire to help others. The students are always inspirational to me in terms of how much they have hungered for this kind of opportunity. And then really working with them to align their interests in the context of what our community partners are asking in terms of what do they need? What do they want? What's going to be beneficial to doing things? And I'll give a couple of examples real quick in terms of how we've done that. One is looking at lead distribution in the environment, actually kind of characterizing how much lead is on a particular porch, how much that gets inside a home, how much are people exposed to. Another is working with the Kepler Institute. They're developing an urban farm just to the south of town, still in the city, as a resource, but it's impacted by a chlorinated solvent plume from an old dry cleaner. So they're impacted by how can they or can they not get water from the ground to be a resource for that farming and cultural center that they're working on building. And so we've had a number of students looking at the subsurface geology, the contaminant hydrogeology, things like that, and then bringing this sort of actual evidence. Where could we put a new well? How will we sort of mitigate this kind of thing? How can we make this a safe and functional sort of environment for this urban farm as a resource to that community? And there's been several other projects. I know I could go all day, but we have other time for that. In the meantime, it's a pleasure to introduce the 2025 Bantz Community Fellowship Award. And I can say that I have really appreciated, Dr. Bantz, this opportunity to translate my environmental science into the community. And hopefully this is empowering also the university and our students. And I think what Mary and Katie, who are going to be up next and tell you even more about this, are doing it's really exciting is in terms of developing a website and really a way to kind of bring this idea of how to make information about self-management, healthcare navigation, preventative care, et cetera, accessible to folks with intellectual and developmental disabilities. And one of the things that I was really struck by in talking to them and looking at their website was the idea that you can't really do this without listening to them, right? Getting an idea of what they need and what is it that they're doing at this website and trying to provide this information. How are they perceiving it, right? Getting that to be more effective. So really exciting sort of philosophical approach to me in terms of how they're doing that I think is super exciting. And I wish them the greatest luck and I'm sure it doesn't come down to luck, but it's an exciting project and I'll let them tell you more about it.
Charles, do you want to be in a picture with them?
Sure you do. Hey, it's cool.
It's really cool.
Come this way a little bit.
Okay, sure. Yeah.
All right, so just to share a brief history, Mary and I started working together during my residency here at IU. We continued our work together in the Center for Youth and Adults with Conditions of Childhood, or KAYAK, back in 2007. At KAYAK, we have a multidisciplinary team of physicians, nurses, and social workers who help youth and young adults with intellectual disabilities and physical disabilities and medical conditions as they move from the pediatric world into adult life. So we learned from working with this patient population that there's a real need for better healthcare supports for persons with intellectual and developmental disabilities. To meet the need, we culled information from peers internationally who are doing similar work, but also from patients and families. Where there were gaps, we've built resources. So fast forward 10 years to the launch of the Indiana Complex Care Coordination Collaborative, or IC4, which is a statewide project to improve care for children with medical complexity.
So in 2023, we got a ARPA grant from Medicaid or a state federal FSSA office to start to do some specific work with both children with medical complexity and adults with intellectual and developmental disabilities. And we were able to use that funding to launch work in building a website. And we were already collaborating with Special Olympics, who do wonderful work in inclusive health and really are strong national and international advocates for the needs of patients and persons with IDD in terms of healthcare. And I also get to volunteer at an organization called the Village of Marici, which is a community of adults with IDD on the northwest side of Indy up into Hamilton County. And so we talked to them and recognized some of their critical viewpoints in what we wanted to build. And the Special Olympics has a organization called Athlete Leadership University, or ALU. And this is an opportunity for athletes to build their leadership skills. And once they complete that, they are to do internships that apply what they've learned. And so that was a perfect setup for us of these health and wellness interns who were looking for work to do in health and wellness and represented their community. And so we partnered together and created a team that began to have a lot of fun together.
And then to bring in the student part of things, of course, in our clinical work, primary care, IC4 and kayak, we've met lots of students who have passion and care for people with disabilities, whether it's meeting them in kindergarten or having a family member, but there are a lot of people in the community that really also see the need for this specialty care. So we have two students, Lauren Alexander and Lizzie Roy, who we have worked with fairly recently that were very interested in kind of partnering with us to move our work forward. So the two of those medical students and Mary and I and our team of 6 Special Olympics athletes now have this collaborative team where we meet by Zoom every week and kind of go through some of the resources we've developed. We get feedback back from the athletes, make our project better, or we make revisions, send it back to them for approval until they say, hey, this is great. It's a lot of fun to work with them. So we've done things like create videos for what to expect when you have a healthcare visit. We've put together social stories and other social visual kinds of tools, as well as we learned very much that we engage our patients or these individuals a lot more if we play games. And so we've added a lot of interactive components and games to our website, thanks to that teamwork.
And so the individuals on that picture are a lot of the folks you'll see in a number of the videos. They helped make the scripts. They corrected us when we were missing the mark. And it's really grown into a very pleasant collaboration. So the site's now ready for us to expand to a larger audience. So with the Bantz Award, we're going to do a formal usability study where using computer observations with mentors who then watch the individual engage in the website and measure their use. We also have some very easy read quizzes to test pre and post learning in the users, and some Zoom recorded observations to help us catch where their eyes really rest, where they skipped because we missed the mark, and all of that work together. We hope to make even a better site. We have our first, we've done already some pilot work in this last 2 months, but our real launch is next weekend at Athlete Leadership University, and we'll collect 30 observations during a scheduled period then. And we have another couple of events coming up shortly thereafter to hopefully get up to our number of 80 to measure functionally, statistically, whether it's a good website ready for the larger world, or how much further back we have to go to our drawing board.
Thank you. Congratulations. And you'll have a chance to talk with both of those fellows afterwards when we get into the other portion of this. But next, we want to get to the next award. We have one other award that we like to celebrate. This is the Bantz-Petronio. Translating Research into Practice Faculty Award, which was initiated by Charles and Sandra back in 2013. And it recognizes somebody whose work is very well known and very internationally acclaimed in many cases. So now we're going to introduce Dr. Sherry Bucher from last year, who was the 2024 Bantz-Petronio awardee. And she's going to just give a brief update on her work, but then introduce this year's awardee. So come on up.
Thanks, Stephen. It's great to be here today. I'm really, really, really excited and very excited to give a very brief update on some of the work that we've been doing in the year since we received this award, myself and my team. Oops. All right. So I'm just going to talk about quickly 3 research projects that we're working on in the past year. One is to develop tools and solutions for less invasive screening to reduce the leading cause of preventable blindness around the world. A second one is to teach babies how to tweet their clinical condition to the nurses who are taking care of them. And the third one is to increase access to evidence-based well baby care among marginalized communities in Marion County. So retinopathy of prematurity is one of the leading causes of preventable blindness in the world. There are about 15 million babies a year who are born prematurely, and a great number of them suffer from ROP. This is a vascular condition where the blood cells in the back of the eye grow so rapidly that if not caught and treated in time, it can actually detach the retina and lead to lifelong blindness. Some of you may have heard of someone named Stevie Wonder, who is a survivor of ROP. He is blind because he was born prematurely and suffered from ROP. Now, we now have much better treatments than we did 60 some years ago when Stevie Wonder was born. We know that we need to screen babies, and we know that when they get to a certain stage in their illness, we need to treat them. But as you can see from the slides here, it is not a pleasant condition for babies to be screened for. It also requires really highly trained pediatric ophthalmologists, and it requires some specialized tools. So we have this team that we're working with in Indiana CTSI, and in particular our collaborators at Notre Dame, who have developed what I call a Star Trek innovation to try to address this gap that we have in low impact screening for ROP. So prior to about 2 years ago, the common belief was that babies, newborns, could not have an iris image taken. You couldn't get a picture of the front of their eyes. But my collaborator, Adam at Notre Dame, has designed both the hardware, a scanner, and the computer vision algorithms, which we have now proven with some NSF funding. We are able to capture pictures of the front of a baby's eye, and we're able to accurately analyze the textures and the patterns and how those change over time in the baby. So now that we have the hardware and software, for the first time in the world, we are able to ask this hypothesis: can we detect changes in the back of a baby's eye by taking pictures of the front of the baby's eye? We don't know if we can do it or not. It's kind of a bonkers hypothesis. It's Star Trek. But we presented our preliminary work at a computer vision conference in February, and our student won the best paper award at that conference for the most robust and most novel application of new technology. So we think we're on to something here, and we're now working with collaborators in Kenya and India to gather more preliminary data and technical feasibility. So stay tuned on that. The second area that we're working on and that we've achieved some updates since the last year is to try to help teach babies how to tweet their clinical condition to the nurses and parents who are taking care of them. One of the challenges when you work with newborns is that they can't tell you how they're feeling. But newborns tend to have this sometimes slow decline in their clinical status, and then suddenly they just fall off the cliff. Usually we capture this by routine vital signs monitoring. But in places like sub-Saharan Africa and India, where I do a lot of my work, we don't have the workforce. We don't have the number of nurses that are necessary to take a baby's vital signs every 4 hours around the clock to capture their slow decline. So we often only capture babies after they've had a crash. It's very hard to bring them back from that. So we have developed a biomedical device called NeoWarm, and it's bundled with an app called NeoRoo. And we are now collecting preliminary data to see if we can use machine learning algorithms to analyze the vital signs information that we're capturing, combining it with assessments from very experienced neonatal nurses to see if we can build a digital health tool whereby babies who are wearing this device can tweet the information through their vital signs to the app. It has clinical decision support built into it. It has automated risk stratification. So if a nurse sees a baby go yellow on her phone, she knows she needs to go check on that baby before he goes into the red zone. And finally, we are doing a lot of work here in Marion County. People are probably aware that Indiana has a really big challenge with infant mortality. Now, we had some celebrations a few months ago when we found that the overall rate in Indiana of infant mortality had dropped to its lowest historical levels ever. That's something to be celebrated. But the fact still remains that we have unacceptably high overall rates of infant mortality, and we have really high rates among our non-Hispanic Black families. So we've developed a program called Baby Village, which the Fairbanks School of Public Health is implementing in collaboration with the Haitian Association of Indiana across 5 zip codes in the far east side of Indianapolis. We're using community anchored, linguistically appropriate, and social support to help link families to the American Academy of Pediatrics well baby evidence-based preventative care schedule. And so we're hoping that within a year, this is a pilot project. We're hoping we will demonstrate that it is feasible and acceptable. We're hoping that we will show that it will eventually be scalable. And this will be a way for families to access that important care that they may not be able to access in clinic setting. And I just want to give a real quick update on 2 partnerships that have really expanded in the year since I last spoke with you. One is our partnership with Amrita University in India, where we are doing work across the portfolio to try to help strengthen health systems for mothers and babies. Indiana University, Indianapolis signed an official memorandum of understanding to collaborate and to develop a joint virtual center for excellence for data for good with Amrita in January. So we're part of those efforts. And then of course, our work continues in Kenya, not only with our colleagues at Moi University and Eldoret and Ampath, but also with our colleagues in Nairobi at Jomo Kenyatta University of Agriculture and Technology and the Mama Lucy Kibaki Hospital. Translation of research into practice is a very powerful and important tool by which to improve human health and well-being across the lifespan. Individuals, families, and communities all benefit when TRIP scholars apply their knowledge and expertise across the entire breadth of human development from the cradle to grave. That's why I'm really excited to be able to introduce Kathleen today. You've just seen some work we do on the newborn, and Kathleen is on the opposite end of the pipeline. And she is a nationally recognized leader in geriatric medicine. Her work perfectly embodies the mission of the Bantz-Petronio Translating Research into Practice Award. She's dedicated her career to ensuring that older adults in nursing homes receive care that's compassionate, evidence-based, and sustainable. As a principal investigator of the landmark Optimistic Project, She led a $30 million federal demonstration that redesigned nursing home care to reduce unnecessary hospitalizations. That program not only improved patient outcomes, but also drove statewide policy and inspired a new company, Probari, which brings research innovations into everyday practice. She's continued this work through initiatives like Uplift, which focuses on palliative and end-of-life care, generating evidence that informs both practice and policy. At Indiana University and Regenstrief Institute, Kathleen is an outstanding educator, training the next generation of clinicians and researchers in geriatric medicine and palliative care. Simultaneously, she continues her own clinical practice in nursing homes, and this ensures that her scholarship is anchored in real-world practical experiences of patients, families, and staff. Kathleen, your achievements exemplify how research can be translated into compassionate outcomes, measurable improvements in people's lives. It's a great honor and privilege to introduce you as a 2025 Bantz-Petronio Tripp Scholar.
Thank you so much, and so inspiring to hear about your projects. And yes, I am at the other end of the spectrum here. There we go. I got it. Oh, I can use this. Yeah. Okay. So I'm really excited to talk about nursing homes for a little bit here. My favorite topic, and that I have been leaning into for decades here. Who here has been in a nursing home? Okay, most people. I started volunteering in nursing homes when I was a kid, when I was 10. I would go with my grandma to visit friends of hers, neighbors of hers. And I think, when you raise your hand if you're reflecting on some experiences, walking through the door of a nursing home, spending time with people you know and care about in these settings, that maybe you felt at times how I've felt when I spend time in a nursing home, which is, surely we can do better. Surely we can do more, particularly given the amount of resources that we spend to provide this care and to support people. Surely there are other ways that we can do this. And so that's what I'd like to talk about today. I'm sure you may have already noticed the names of the projects: Optimistic, Uplift. There is a lot of despair, I think, that people have when they think about long-term care, post-acute care, and the conditions that people have in these settings. And so I do believe we can do more for people and do better. And so our teams, we always are trying to think about that, to think about that lens, to think about what can be, and we build that into the names of our projects to keep us centered on that. So again, it is my favorite topic. I can talk about it all the time, but I am not, I understand the realities of nursing home care, and I do want to review some of that just to level set us. I do think there are a lot of opportunities for research to help us point the way of how we can do this better. And I'd love to talk about both Optimistic and Uplift, as well as Next Steps, which is a newer large initiative to enhance clinical trials work in nursing home settings. Probari, this is both a disclosure and to share that Probari is a healthcare startup that I and a nurse, Russ Evans, that I worked with closely on Optimistic, founded following the Optimistic demonstration project. And I don't talk about Probari at all in this presentation, but I'd be certainly happy to answer questions about that entrepreneurship path as well. Probari means proven in Latin being my undergraduate degree that I never get to use. So I was happy to pull it out as a nod to taking evidence, into impact through entrepreneurship. But nursing homes. So There are a lot of them in the United States of America, between 15 and 16,000 nursing homes. Now, assisted living facilities, there's really about double that many, although they certainly range in size. But I'm talking about nursing homes, which is the highest level of care. Nursing homes are kind of tricky places, though, in terms of trying to deliver both rehab, or this post-acute after a hospital stay, trying to get you stronger with physical therapists, that rehab focused care, as well as long-term care. So in the same building, you have people who have goals to get better in 20 days and get home, and other people who are going to be there for the remainder of their lives receiving supportive care. So in Indiana, we have 534 nursing homes. We actually have a lot, given the size of our state. The average size of a nursing home in Indiana is about 80 beds. I've been in 400-bed nursing homes in New York City, but the average is around 100 beds across the country. Nearly all facilities, and really all facilities that I know of, are Medicare and Medicaid certified, because that's who pays. That's who pays for nursing home care. Medicare pays for those days right after someone's in the hospital, and Medicaid, though, is paying for that long-term care. Like a lot of our healthcare sectors, the majority of nursing homes are for profit, and there's also a lot of private equity involved in nursing home ownership now, just like hospice and, again, other sectors of healthcare. Nursing homes are enormously expensive for an individual. Nursing homes provide 24-hour round-the-clock care, and most people who enter into a nursing facility, if they are not Medicaid eligible when they enter into the facility, become Medicaid eligible over time because of the high cost of care in that setting. And thus Medicaid is the dominant payer of these facilities. So now the residents. So you are not in a nursing facility for long-term care, certainly, unless you have some combination of cognitive impairment, functional impairment, needing help with just basic activities, getting to the bathroom, help taking showers, help with eating, and complicated medical issues, usually multiple of them, right? So insulin-dependent diabetes plus moderate dementia plus some mobility issues. And again, cognitive impairment and formal diagnosis of dementia is prevalent. So it is really, part and parcel of good nursing home care is good dementia care. And again, sadly, as any of us who have spent time in the setting, I hope that you've also seen even moments and examples of this care being delivered well, of the staff, who are dedicated, who've been a director of nursing for 20 years in a facility, who have a true heart for this population and this work. I've seen a lot of good nursing home care, but it's hard to do it consistently, and even in any place. And so there is a good documentation of quality issues across nursing facilities and issues around pain control. And then this notion of frequent burdensome transition. So bouncing back and forth to the hospital is a big issue. This is now an old report, but there are other, when there have been large reports trying to characterize the number of adverse events or issues in nursing homes, it's always higher than you'd want to believe. So why all these challenges? There's a number of reasons, and just to highlight a few of them. The path into a nursing home, sometimes people enter into a nursing home with a plan for long-term care. Most people with dementia are cared for at home. But sometimes after many years of being cared for at home, then people receive care in a nursing facility. So sometimes that is a decision to transition into a nursing facility. Almost always, though, the path is via the hospital. You get discharged to a nursing facility from a hospital, and then potentially from there, you become a long-stay resident. But the path is usually through the hospital. And then once you're in the nursing facility, this population is certainly high risk, right? For infections, for falls, for all kinds of issues that take you back to the hospital. And it is just pretty unbelievable to me that we haven't solved some of these issues about communicating across settings of care, but we haven't. And so communicating across settings of care, communicating with family members who are the voices and the advocates for people living in nursing facilities are consistent challenges. Nursing homes do have electronic health records, that they were certainly slower to adopt them than inpatient settings, but now almost every nursing facility has an electronic health record. It's harder and harder to find. Some you still use a lot more paper than I would like, but really we do have electronic health records. Of course, are those compatible with, and do they talk to the hospitals? No, but we do have them. So there's some resources there. I hear a lot from hospital leaders that they're very frustrated about nursing homes, that they, want X, Y, and Z, and they'll call a nursing facility. They'll have a team call a nursing facility to talk about 2 patients that came back, right? But I don't see a lot of hospitals putting real resources into nursing facilities. They're discharging a lot of people who've had orthopedic surgery. Are they sending a nurse there to round on those folks and help educate the staff about how to care for people with that? Like, I think there's a lot of opportunities to share resources for mutually aligned goals across settings. I really came to be, the more I learned about palliative care while I did a geriatrics fellowship, and while I was in my geriatrics fellowship and spending time in nursing homes and learning about palliative care, I really came to see palliative care as, again, like this concentric circle of good dementia care, good geriatrics care in the nursing home, and palliative care. Like, I think there's a lot that specialty palliative care can offer in this setting, very uneven access. And then staffing. Can't talk about nursing homes for more than 5 minutes without talking about staffing, specifically staff turnover. And this is highly relevant to doing research in this setting, because when you think about doing research in this setting, who is it that you want to do things? You're going to ask the staff to do things or to do things differently. And so you're trying to impact workflows of a workforce that's, turning over. And so it's just a reality running in the background. I was very aware of this when we started Optimistic here back in 2012. What is also difficult, and I think it's also in this paper, I just don't have the table here, is the high rates of turnover of the leadership of nursing facilities, executive directors, directors of nursing. And that's tricky. If you've got an intervention that, is 2 weeks or 4 weeks, and you can get agreement signed, you can go in there and you can see the impact of X, Y, or Z over that short time frame. But when you're trying to run projects that are going to last 6 months, a year and a half, we're going back to do data collection in one of our projects, and you've got facilities changing ownership, changing executive directors, it's just going to happen, and you have to have a plan for it. So briefly about Optimistic. What an amazing opportunity this was. I was 6 months on campus when the fairly newly created Center for Medicare and Medicaid Innovation at that time put out this call for proposals to reduce avoidable hospitalizations of nursing facility residents. And this was very exciting because you talk about complex problems. Why does an unnecessary or avoidable hospitalization of a nursing home resident happen? So many reasons, right? It's the communication, it's all those things. It's the staffing, the communication, the resources, I'm going to list 5 things before I say the actual clinical condition. Of course, that also, right? And it's a complicated problem, and they wanted to put a ton of resources into it. It was a tremendous opportunity. And I was so excited, only being here a little bit, that there were already folks here who were working with Medicaid. So getting a letter of support from Medicaid wasn't hard to do. There were other folks who had some connections with nursing homes, able to connect with nursing home partners very quickly, because you had to have all your nursing homes recruited before you even started the program. So there were already people doing not exactly this, but enough that we could build on, as well as partnerships with the University of Indianapolis and other organizations in our state. We ended up working with 40 facilities across the state of Indiana on Optimistic. And it was 2 phases. So, and that's how, that's why it's 30 million total over the 8 years. So in phase 1, we got to put a clinical model into place. So we actually got to hire RNs and place them, embed them in nursing facilities and give them a new role, right? So all those gaps, all those problems, a lot of them, a well-trained RN can address. And so we got to deploy RNs into buildings to be focused on advanced care planning, palliative care, rapid recognition of change in status, and training all the staff up on these things as well. Root cause analysis of transitions that do occur. And we hired nurse practitioners who would float among the buildings to support as well, to see sick residents if their primary care provider couldn't get in there. In phase 2, we got to expand. So phase 2, Medicare and Medicaid finally, well, really Medicare had the guts to say, maybe we should address the economic incentive to send someone to the hospital, because I didn't mention that one yet. Medicaid and Medicare are both paying for nursing homes. Medicare pays more. Medicare pays a fair amount more. So if someone is sitting there and Medicaid's paying day to day for that stay, and they get pneumonia, and now they need a lot more care and attention, right? Because they're sick, a lot more monitoring. No one's paying you a dime more to have the nurse spending more time there, to have the doctor see them. Well, doctor can bill, but anyway, the nursing facility, no one's paying the nursing facility more to provide that higher level of care. But if that person goes to the hospital, yes, you're out those 3 days so they can have a qualifying stay, but then they come back as a Medicare bed, a Medicare person to their exact same bed. And then the nursing facility, Medicare will be able to bill Medicare for that enhanced higher level post-acute care stay. So one of the underlying issues, which, Medicare was aware of, was, well, maybe when people get sick in a nursing home, we should pay the nursing home for that episode of care to take care of someone. They do this through managed care. They were doing this on the managed care side, but not in the fee-for-service world. And so they didn't have the guts to do that, though, until they had first tested the clinical model, right? And had the nurse staff in there, et cetera. And we could assure them, yes, we know how to take care of sick people in nursing homes. Yes, we can do this. Resources would also be nice. So phase 2 was great, because I got to go to these nursing homes that it will never be so easy to recruit, right? For any project, because these 19 facilities, I got to say, hey, these nurses that have been such an asset to you, you get to keep them for 4 more years. And also now, when they help you identify someone who is having a pneumonia episode, heart failure, COPD, there are 6 conditions, common conditions, then you can bill Medicare an extra couple $100 a day on top of that Medicaid payment to provide enhanced supportive care to that resident. And then we got to recruit 23 other facilities and say, okay, you don't get a nurse, but you can bill Medicare for these episodes. And so yes, it's just a little bit more detail about what we had those nurses do and nurse practitioners do. But again, tremendous project. We developed a ton of resources, throughout the 8 years of this project. Those 23 facilities who didn't get the nurse, they ended up, I thought we would just explain to them how to bill, and then we check in with them again in 4 years. They needed a lot of technical assistance, hands-on support. And so we ended up sharing a lot of these tools with them and helping them get things into practice. I mean, they would have their nurse practitioners or physicians come into the building, see people, and leave without ever interacting with the executive director or the director of nursing. And because they had an incentive to identify exactly when someone was starting to get sick, they created new patterns where they would sign out every day and, get on the same page. Again, things that you would hope are happening anyway in the usual clinical care and workflows, but how you set up the incentives and the payment matters, because the practitioners involved will alter the way they do things. So that was optimistic. And of course, the best news of all is that it worked. So the potentially avoidable hospitalization there reduced potentially avoidable hospitalizations by a third compared to control group facilities in Indiana. This is not a paper we wrote. This was the external evaluators that CMS hired. There were 7 sites across the country that participated in the larger demonstration project. Optimistic's just the Indiana one. We and Missouri, we were the 2 that had positive results. They also embedded staff in buildings. The ones that worked, we were more hands-on and interacting with the nursing facilities. Others were more like, we'll give them their data, and they'll be able to look at their trends and their patterns, and we'll kind of hand them tools. But we were much more like, we're going to be in there doing things, and that direct care, that direct model made the difference, and it worked. And even with all the money they gave us, they still saved money on that project. And then one of the most gratifying parts of the Optimistic demonstration project, which at this stage of my career feels obvious to me, and I wouldn't want to do a project without this now, but at the time, I underappreciated what an ongoing asset it would be. And we had this advisory board, this stakeholder advisory board that met quarterly for 8 years. And once a year we did it in person, like an evening, a dinner. And then once a year, that meeting was a half day. And we would be sharing what's going on with the project, getting feedback. It was really cool. We had the nursing homes there, but we also had Medicaid, Department of Health, the Alzheimer's Association. We had the EMS provider. So we just, and like, I would literally collect people along the way. If I met an organization, I was like, you should come to our advisory panel meeting. And it really was a rich environment to keep this project connected to the ecosystem, and also to create a really positive environment for, again, like, how many times have you seen a story in the news about nursing homes and it's been positive? I challenge you to think of one. I mean, during COVID, right? You can remember that. I talked to a lot of reporters at that time. They were always trying to talk to people about nursing homes. It's hard to find things to celebrate. This we could celebrate, coming together on this project. So for 8 years, we really leaned into that. And it was a big part of that project. And so this is just some of the papers we published and some of the presentations we did, and some of our nurses and some of our staffs. But that was, anyway, it was a blast. And I am glad to still be working on it now through the legacy of ProBari. I do want to highlight Uplift. Uplift is a clinical trial. And so Uplift is, the goal of Uplift is to kind of figure out a model for delivering palliative care in nursing homes. What could this look like? And the co-principal investigator is a PhD in social work, my colleague at the University of Maryland. And then we also have a nurse leader on this team. So we feel like we're the interdisciplinary team to pull this off and think this through. Palliative care could be its own talk. So just very briefly, to say that palliative care, and again, I think it's a really strong fit for the nursing home population, because it's focused on providing relief from symptoms and stress of illness. There are things we can treat and optimize in the nursing home setting, but there are also a lot of problems we cannot fix. And palliative care is designed to support, optimize quality of life, communicate with everyone involved. It really philosophically is such a strong fit for the kind of care we want to provide in this setting so often. And what data there is good, not a ton, but what data there is for palliative care in nursing homes has shown an improvement in some of those problems I highlighted earlier about pain control, symptom control, unwanted, unnecessary hospitalizations, and frustrations from family members. But this is one of my patients who was 102 at the time of this picture, and one of the optimistic nurses. I always love seeing him on my slides. But But what is a palliative care program in nursing homes? One thing that we've struggled with is defining this. And this is a real challenge in research, especially when you want to be applied and you just want to be out there in the world doing things. We have to define kind of what it is, because I've talked to a director of nursing at a nursing home who's like, oh, we do palliative care. And I'm like, really, can you describe it for me? And then what she describes is not something I would recognize is palliative care. It doesn't have any specialty palliative care providers in that. And so I think, you know, this is this real tension, I think, is you know, when you're talking about something like a model of care, you know, you have to kind of create some definitions around it, some clear, you want flexibility, you want to be able to implement in a whole range of different settings, but you have to have some clear, and that just kind of doesn't exist. So every time I talk to any of my colleagues doing research in this area, I tell them, like, we have to define it. Like, it is up to us who do work in this field to define it. So we are like, we're just putting a stake in the ground. This is how we're defining it for this project. We feel that palliative care in this model, we're going to have to work on building up resources in the building. And then we also are going to bring resources from outside the building. So we're training folks in-house on some of the basics of palliative care. And then we had specialty palliative care consultants come into the facility. I was kind of tired of avoidable hospitalizations as the big metric and outcome. After there's a couple studies that aren't in here, but that's just so darn easy to measure. And it does matter. It matters financially, but it also matters for anyone who's spent 10 hours in an emergency department with someone with dementia. Like, it matters. It's an important outcome. But I wanted one that was more closely tied to what palliative care is doing around symptom management. We did a ton of data collection, a ton of primary data collection in this study, from staff caring for the residents, as well as from family members of the residents. Asking them about their symptom experience over the past month. Have they experienced, you know, this whole list of symptoms? And we did have our primary outcome based on staff. So the goal of this project is to describe a standard for palliative care, also provide a roadmap of how to do it, how do you actually implement it and get it done, and demonstrate efficacy and impact on the resident experience. And we're done with this trial, and we're just analyzing our data, and I'm pretty excited about it. And really, I'm very excited about it. And so hopefully more to come on that soon. And then I'll finish up by talking just a bit about next steps. So next steps is it's a National Institute on Aging. It's a U24, and these U grants are these large infrastructure grants. And this was another one where, like the optimistic one, where I read the RFA and all I could think was, yes, good. Thank you for investing in this. So the National Institute on Aging talked about during the example was, and it is the example, during COVID, there was so much urgency on developing tests and treatments, develop tests and treatments as fast as you can. They were not tested on nursing home residents. I think during like all of COVID, any major therapeutic or diagnostic test, I think maybe like 200 nursing home residents ever participated in any trial out of all of the trials and studies and everything that was going on. And then it was approved. And if you'll recall, number one population for access to it, people in the ICU, healthcare providers, nursing home residents. Then there was immediately this outcry if all nursing home residents who had COVID didn't have that test or have that therapy. But if you don't bother to test it, if you don't do the work of doing the trial and doing the study in the setting where it's intended to be delivered, then you aren't figuring out all those implementation issues. And we had to figure that out after the fact. And so, of course, it was unevenly distributed. So this happens all the time. That is just a glaring example. But there's all kinds of potential therapies that we lack an evidence base in our setting. Not everything needs to be tested in a nursing home, but the things that do aren't getting tested in a nursing home because apparently it's hard. But there's all these papers saying that about all these reasons it's so hard to do research in nursing homes. However, this is designed to address that directly, to bring people together who are doing it and who have had success doing it, who enjoy doing it and have found it meaningful, and to figure out what infrastructure is needed to do explanatory clinical trials in this setting, and create some infrastructure around that. So this is our model that we developed to help us think through what does it take to do a high quality clinical trial in a nursing home setting. And we've published this figure and this model. What do we have to think through when you're designing an intervention? How do we ensure equity? And for example, if they're under less resource nursing homes are going to have more turnover. So if it is important, if you want this to be delivered in lower resource nursing homes, then you better staff up on the research side to be able to support those facilities and testing it in that environment. You can do it, but it's going to require more work on the research side. So can you budget for that? Have you built that in from the beginning, right? So recruiting nursing homes. Recruiting nursing homes is challenging. It was challenging in Uplift, especially in Maryland, because they hadn't had the benefit of just doing Optimistic and already knowing so many folks. But just as important as recruiting is this engagement throughout the trial. So if you're going to do a longer trial, Uplift was a year, then you're going to need to be ready to deal. You need to already have like your little module built for when there is turnover of that champion, how you can get the next person trained up, et cetera. And then we do have a fair amount of data in nursing homes. That's like actually a really good news part of it is there's a lot of data that's collected because of the billing, right? And Medicare and Medicaid, et cetera. There are assessment instruments. We have a lot more data on people receiving care in nursing homes than we do on the many people receiving care at home who are similar. And so what are the best data sources? What are the best outcome measures for this population that are meaningful? And then how do we follow up and follow through with these partners? Certainly for me, I always want to do a good job because I'm going to call them up for the next research study, right? I want them to keep participating, and they will only do that if we've got a plan, to follow back up, understand what they're getting out of it, right? How are we a good partner? Are we giving them tools and trainings that they can share with staff? So we are a year in. This is we have a nice website for next steps, and this is how we're built. We do have advisory panels for next steps. This healthcare providers and advocates, this advisory panel, this is the one that's pushing us. This is, consumer advocacy organizations, trade organizations, professional organizations, Alzheimer's Association, national organizations that represent we have National Social Workers Association, the pharmacy, represent all these different disciplines working in nursing homes and consumers and families. And they are pushing us and will continue to push us. So, and everyone was here this month, September 9th and 10th at Regan Street. We hosted the first annual meeting where folks came from all over the country together. And it's so wonderful to host things in our city. It was great to have everyone here, to have everyone in person celebrating the first year of this project, but also talking through some of these thornier issues and how are we going to navigate them. And this is amazing that the NIH has put $16 million into this, or $15 million into this 5-year effort. How are we going to spend every dollar to expand high quality clinical trials that are impactful in this setting? 30 of them went to a fever game. It was a blast. It was a lot of fun. So there are numerous challenges and barriers to achieving consistent and high quality care in this setting. And there's just, and I do think that rigorous clinical trials can be part of the answer here to help us feed and develop that evidence base. But there's just too much of this feeling that it's just too challenging to do research in this setting. And I've also talked to people who like did a pilot and it didn't go well. And then they're just done. They're done with nursing homes forever. So how can we support people to have positive junior investigators, to have positive experiences and to stay with it over time? So despite significant need, given the morbidity and mortality in this population, people are just left out of clinical trials. But I think we absolutely can, and we are directly addressing it. And I do think, I mean, this, just speaking directly to this award, to this effort to recognize like what's the point? Why is it that we do what we do? I do think research can be a path to advance practice and to impact care in partnership with, in my case, the nursing home industry, with families and residents in buildings, with practitioners in this setting. We have to just address the implementation challenges. Anytime you're working in a messy environment, a complex environment, you have to sort through that and address them. And we need roadmaps to do that. We need to test it out, and we need create roadmaps so that a large nursing home chain can implement palliative care symptom ride, right? We want to make it as easy as possible to give them the tools and the maps to do that, and to integrate into existing workflows. We have to, though, have outcome measures that are meaningful to residents and families. And it's hard because we're often pushed, certainly I do a lot of work in the pragmatic trial space. We're pushed to use existing data. And so, we have a lot of existing data, but it doesn't always measure exactly what we want. So there's, again, another tension there. How can we collect data pragmatically, use data pragmatically, but also find outcomes that are relevant to residents and families? So again, a challenge, but we're addressing it head on. And then, I was talking about Medicare, I was talking about Medicaid. Like, there's so many policy issues that impact the care of people in nursing homes, or really across our systems. And so, we need to understand how these shifts and changes in policy and industry play into and impact our world. And to end on a positive note with that, how it can create incentives and alignment to adopt new models of care, adopt new programs. So I'll end there. Thanks so much. There's my 4 girls.
Thank you.
Thank you so much.
And we'll do the Q&A afterwards.
Okay, great.
Well, give her a big round of applause, please. You'll have a chance to ask questions and dig more into it with all of our folks in just a little bit. But before we get going, we want to thank and congratulate all of our awardees. Give them a big round of applause. And now it's my pleasure to invite Amy Warner, who is Vice Chancellor of the Office of Community Engagement, to come forward to talk about how we keep these awards going. You may not know that the Bantz Fellowship comes with a $40,000 award for the faculty member to do a year's worth of work on top of other things that they find. And this award that you just heard about comes with a $1,000 award in recognition of the work that's happened. But we got to keep that going. And so Amy's going to help us figure out how we do that. So give Amy a welcome.
I don't know if you're half as inspired as I am by what we've already heard, but these stories of the connectedness between our faculty and the community and the science is something only a university can do. And when we're at this period of our lives where you're hearing these horrible things about higher education and restricting funding for research and doing these kinds of things, this is something that should be absolutely celebrated, not just today, but in everything we do. So congratulations to everyone, all of the posters that have been here. As you know from Chancellor Bantz's earlier comments, when he and Sandra arrived, clearly Indianapolis was not business as usual. clearly this was in fact a place that is connected to the community, and we are interdependent with each other. So starting these two important these important fellowships, we want to continue this work. We have had over the years a number of awardee winners. These individuals are literally from education to law. They're from science to liberal arts. They're from Heron School of Art to the School of Medicine, and it literally touching every corner of this university. There are also over 205 scholars that are recognized on the Translating Research into Practice website. And each day, by listening to all of you and the colleagues that you've mentioned, there are even more scholars that have chosen to keep this work going. What we're inviting you to do is I want to introduce, and Isaac, if you can wave. Isaac is joining us to help us build the fund that permits us to make these awards and even grow this opportunity for more scholars. So if you have interest in joining us as a donor, please do. The QR code is here for you to be part of that. If you don't know that this is something that's right for you, but you know someone that Isaac should reach out to, just let Isaac know who they are and their number or their email address, and that you've recommended them. He will bring them into the family of IU Indianapolis and bring them into the great work that you're doing. But I know he's ready to do that. And to those of you who have joined us in sponsorship and in support for the work that's being done, we hope that you'll continue. I know I'll continue my financial support for the programs as well. So thank you for coming. And I know you'll be able to see many, many other stories from our colleagues are here. And I do think maybe Virgil Gregory wins the number of relatives here today. So Virgil and his family, welcome. And hopefully your family will be back with you with your poster too. So thank you all for coming, and we hope that you'll learn more from each other throughout the rest of the program.
As you may know, Amy is an amazing supporter of our campus and has been a great connector for the community. So she's getting ready to retire, believe it or not. So let's give her a big thank you and a round of applause for her amazing work. Well, we hope that you will take her up on this opportunity to become part of the family in some other ways, or recommend folks that we could talk to, because that's how we want to keep this moving. A couple of things. Let me ask that our poster presenters, the 6 of you, would you come up over here and just be ready? Come stand over here, because remember, it's going to be time for your 30-second lightning introductions. So come all the way up here to the front. While they're coming, I just want to highlight a few things for you. We hope that you'll go check out the Center for Translating Research into Practice website. There's lots of things there that you can find. You can learn more about translational research, look up those over 200 translational scholars, call them, email them, meet them, find new connections. What happens often at these events is we make new connections and have new projects, and we solve more problems. So let's take advantage of that and to learn more of what we can do. Another way that we share this information is with our partnership with ScholarWorks. Jerry Odell is here from the library today. We have an amazing partnership with ScholarWorks. You can go to our website or to the ScholarWorks website and get access to a huge number of publications right at your fingertips, free and easy. The library supporting our translational scholars in the Center for a Trip to make their publications easily accessible to their community partners. So you're looking at a sample of one of our folks now, where you can just see how easy it is to access the materials. The Trip collection on ScholarWorks includes over 4,500 articles and other items that are authored by our campus translational scholars. And collectively, these are viewed or downloaded more than 300,000 times a year. And that collection has generated over 1.8 million open access downloads to date from readers around the world at no cost to readers and authors. So I think that's amazing, and we thank the library for that support. In honor of realizing Sandra's dream, our center is proud of its accomplishments in identifying, celebrating, and promoting translational research. We hope that you'll engage with us in any way that you can to learn more and share ideas about how to make our world a better place. Here's some examples of some of the ways that we are trying to do that to make things better. One of Sandra's dreams was to create a space where scholars could just engage with others to openly share ideas and generate more research and scholarly creativity. So to that end, we've created the Scholar of the Month program that includes a monthly conversation with a scholar to simply learn more about their work and to talk about it, discuss implications and share ideas. We do that virtually. So check out our website. Here's the next two coming up in October and November. So we want to thank our partners for their amazing support and their recognition of the importance of this work on our campus. And now it's time for a speed date with our 6 poster presenters. So I'm asking them to come forward. Come on, I asked you to be closer. I really did. So you're first. So they're going to share their name, what their research is, and so that you have a sense of where to go, because when they're done, we're going to wrap up and have a chance to visit with everybody. So come on around and introduce who you are. You get 6. I'm gonna time you. You get 30 seconds or less.
I'll be quick.
All right. Come
I'll
over
be
here.
quick.
All right.
Hi, everyone. My name is Dr. Kara Taylor. I am a clinical associate professor in the School of Education. My research is around healing spaces. I look at literacy and literate practices as a form of healing from oppression for marginalized populations. So we define that as literate practices as talking, dancing, creating art, any kind of way in which we interact in the world to communicate. So I do all my research with Taylor Box. So shout out to Taylor Box. But we do different research where we collect stories of marginalized populations who might have experienced things from racial trauma and oppression to language violence to any kind of social issue that they've experienced. And we foster a space in which we could create critical discourse for them to be heard, for them to be valued, but also for change to happen. So we worked with different foundations like Children's Theraplay and different therapeutic spaces as well as schools. And we've done a lot of curricular redesign all over Indianapolis to foster healing through policy, through curriculum, through any kind of procedures within a space. And we're not just limited to education. So we've expanded as far as Moi University in Kenya to talk about policy there. But that is what we do. We collect stories, we're a microphone, we generate spaces of healing discourse creation for the purpose of collective healing and for activism and emancipation and liberation.
Give it up, Dr. Taylor.
Good afternoon. I'm Joseph Tucker Edmonds of the School of Liberal Arts and Religious Studies and Africana Studies. I had the opportunity to work with Dr. Virgil Gregory on a project that was on Black male cultural trauma. And part of what I want you to come back and talk to me about is not only our research where we were looking at the experiences that Black men had with cultural trauma, but one of the significant things that I discovered as we were looking through the data, that we thought that Black men were going to be talking only about cultural trauma or mostly about cultural trauma in courtrooms, interactions with police officers, and other kinds of more traumatic intervention or spaces. But we also heard they were talking about cultural trauma as it related to these other safe harbors, where they were talking about hospitals and classrooms, right? And so what my project has led to is that not only getting that information about cultural trauma, but now thinking about Black men becoming doulas in hospital rooms with their wives and supporting services for their children. And so come talk to me a little bit about how we went from cultural trauma to the hospital room.
Good afternoon. I'm Karen Comer. I'm the Associate Director of the Polis Center. And for those of you who don't know, Polis Center is an applied research center, and we focus on working with communities and also with researchers to translate available data, existing data into needed information. I don't know how many of you have heard of the Savvy Community Information System, but it's one of our cornerstone projects. It's where we disseminate all of the wonderful information that is available, and we continue to grow that database through all of the partnerships that we've been involved with the community and researchers. So, and we love to work as a bridge between researchers and the community. So if you're interested in engaging with Polis or learning more about what we do, please come and learn more. And I will do a shout out to ScholarWorks. We're using it more and more, and it's fantastic. So thank you, Jerry.
Hey, everybody. My name is Mark Rattel. I'm in the Department of Kinesiology in the School of Health and Human Sciences. My research is on a 10-year journey in partnership with Wayne Township Stoutfield Schools, how we use physical activity as interventions throughout the school day to promote academic readiness, positive behavioral outcomes, and health outcomes. So if you're interested, I'd love to talk more. Thanks.
Hey everyone, I'm Sylvia Bugatti. I am also going to retire soon enough. I tell everybody this anytime I have a chance. Anyways, I'm here to report on a 14-year community-based research project focused on Latino youth. It's a resilience building identity development project. It has resulted in quite a few other projects along the way. And even after I retire, this will continue. So come and check it out if you want.
Hello, my name is Virgil Gregory. I'm an associate professor at the IU School of Social Work. Dr. Joseph Tucker Edmonds and I, we started our research with Black men as far as cultural trauma. I've now since expanded it to include Black people with substance use. The translational epitome of my clinical work and research work is all in a book that I have coming out called Cognitive Behavioral Therapy with Black Americans, a Principle and Structurally Informed Perspective. Thanks. See you later.
So that gives you a sense of what we have for you in the next bit of time. We have some snacks for you over on the side. I'm sorry, folks that are watching us virtually, you don't get to talk to all these folks. You'll have to meet with them later. But for those of you that are here, we invite you to spend the next time that you have talking with all of the folks, our winners, as well as these poster presenters, and please eat some snacks. So thank you all for coming and enjoy your time.